This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today, we're looking at a fascinating new study from the Journal of Affective Disorders, published in 2026, titled Stereo-encephalography-guided multi-lead deep brain stimulation for treatment-refractory obsessive-compulsive disorder, study design and individualized surgical targeting approach.
This is a timely paper, Ilara. We've been treating obsessive-compulsive disorder with DBS for a while now, primarily targeting the ventral capsule, ventral striatum, or the subthalamic nucleus. But as any of us who see these patients in clinic know, the outcomes can be variable. This study really leans into the idea that we can't treat every brain the same way.
Exactly. The authors lead with the premise that treatment-refractory OCD, or trOCD, is fundamentally a complex network disorder. Because the disease is so heterogeneous, meaning it presents differently in different people, they argue that personalized treatment strategies aren't just a luxury, they're a necessity.
And that brings us to the methodology. For the residents listening, pay attention to the trial structure here. It's a multi-site, multi-stage, double-blinded, randomized crossover clinical trial. That is a very high level of evidence they are aiming for. But the real neurosurgical hook is the use of stereo-electroencephalography, or sEEG.
It's a brilliant pivot. We usually associate sEEG with our epilepsy cases, placing depth electrodes to map a seizure focus. But here, they are using sEEG to guide the selection of multi-nodal targets for DBS. Instead of just picking a standard coordinate and hoping the network responds, they are mapping the individual patient's network first.
Let's dive deeper into that multi-stage approach. In a typical DBS case, we might do a single-stage implantation. Here, the sEEG phase acts as an intermediate mapping step. Dr. Ilara, how does that change our surgical targeting approach?
According to the paper, it allows for an individualized surgical targeting approach. By using the sEEG leads first, the surgical team can monitor the neural activity across various nodes in the patient's specific OCD circuit. They aren't just looking at one spot, they are looking at multi-nodal targets. This data then informs exactly where the permanent DBS lead should be placed to maximize the therapeutic effect for that specific individual.
It's moving us towards a biomarker-driven surgery. For a long time, psychiatric neurosurgery has been criticized for being a bit of a black box. We know DBS works for many, but we don't always know why it works for patient A but not patient B. By using sEEG as a precursor, we're essentially auditioning the targets before we commit to the permanent hardware.
And the multi-lead aspect is also crucial. Standard DBS usually involves 2 leads, one in each hemisphere. This study is looking at multi-lead configurations. If trOCD is a network disorder, it makes sense that we might need to modulate multiple nodes within that network simultaneously to achieve a full clinical response.
For the residents and students, think about the complexity of the planning here. You're not just looking at a standard atlas, you're integrating the sEEG data to identify which nodes are most pathological or most responsive. The paper emphasizes this individualized aspect. It's not just about the anatomy, it's about the specific functional connectivity of that patient's trOCD.
It's also important to note the randomized crossover part of the design. This means patients will likely receive different stimulation parameters or targets in a randomized order, allowing them to serve as their own controls. In the context of trOCD, where the placebo effect can be significant and the symptoms fluctuate, this is the gold standard for proving that the multinodal stimulation is what's actually driving the improvement.
Right, and as a senior attending, what I find promising is the multi-site nature. It's one thing to do this in one specialized center, but showing that this individualized sEEG-guided approach can be replicated across multiple sites is what will eventually lead to a change in the standard of care.
Definitely. It's about precision. We're moving from one-size-fits-all to a highly tailored, network-based intervention. The study design itself is a roadmap for how we might handle other complex affective disorders in the future.
Well, that's all the time we have for today. It's a fascinating study that highlights the evolving role of the neurosurgeon as a network neuromodulator.
Thanks for joining us. We'll be sure to keep an eye on the results as this trial progresses. You've been listening to the Neurosurgery Hub podcast. We'll see you in the next episode.
Stay sharp.